We'd like to open the floor now for questions to our speakers. Yes, please.
Just a quick question to Drs. Berger and Kralnick. I'm wondering if I understand correctly, iris is not necessarily associated, HIV iris is not necessarily associated with the consequences of PML early on, but I'm wondering what fraction of deaths are iris associated. Is there perhaps a stronger correlation there? Whether it's HIV related or natalizumab related?
The published literature suggests that the mortality is no different in the HIV PML population with or without iris. And the mortality right now, as I showed you earlier this morning, the mortality with HIV-associated PML is on the order of 30 to 50%, depending on what series you read. David?
Yeah, maybe I could comment. I see quite a few HIV cases still, and you know, I think that actually what we're seeing at the present time really suggests a greater similarity between HIV and iris and natalizumab and iris than was previously understood. And it really goes back to the scientific need for a clearer definition of what iris is. And Joe, Dr. Berger is entirely correct that it is unfortunate, but we don't have as good a way to diagnose iris as possible. For my purposes, intellectually, the way I try to think about it is from the pathology. And the pathology of PML that is affected by iris is really strikingly different from what we used to see in days before immune reconstitution was possible in most cases where we had patients developing PML. So as a consequence, we had this understanding that the way PML progressed was to be progressive and that there was little inflammatory response. Since I've become sensitized to iris and detecting it, and have watched my HIV cases, to be honest, I don't think I've had a single PML case where I didn't think iris was a part of the current process going on. And I've had much better luck in treating the HIV patients in the last couple of years since I was sensitized to this. I think the best objective data about this, of course, we have this data that we quote about a 50% survival in HIV that came out of a large collection, more than 200 PML cases that had been treated with cidofovir or not. And it didn't matter whether they got cidofovir, but the survival was right at around 50%. So we thought that was really quite a good figure for HIV survival in the current era. In our recent mefloquine trial, I don't think that the supporters of the trial at Biogen will be unhappy if I tell you, but 80% survival was what we saw in our HIV patients in this very carefully followed group of people. And it may have been aided and abetted by the fact that we asked people to enroll only patients that they thought would survive for a month or so we could study them with mefloquine. But I think it actually made very little difference. And in fact, that's exactly what we're seeing. So I think that treatment of iris is actually making a difference, and I think that iris is very common in HIV. Similarly, for the case of the natalizumab cases, I think inflammation is really almost universal. The fact that more than 30% of these cases have an inflammatory MR, which inflammatory MRs, when there has been pathological correlation, has been linked to a very substantial degree of inflammation pathologically. And I believe that there's iris that we would recognize pathologically even before you see any inflammation on scans. So you know, I think that the evidence is that the natalizumab cases start out with inflammatory disease in more than a third of the cases. And the fact that there's a progression which is steroid treatment responsive in many, many cases, if not most of the cases. It may be a transient response, but we see a response. We never saw that kind of response in the pre-heart HIV era. When we treated with steroids back then, the disease progressed without batting an eye. And we routinely in the natalizumab situation see a response that is steroid responsive. So I sort of throw in my intellectual definition of iris, the presence of contrast enhancement where you can see it, but also the presence of a steroid responsive clinical piece of evidence, which I think is as good as we can do without tissue. What we need is tissue, but when we go back and correlate what MR and clinical response and inflammation are seen in, when there's a clinical response, when there's contrast enhancement, anytime we look at the tissue, there's a substantial inflammatory response. And that's absolutely typically what we see in the natalizumab situation.
Yes, please. Introduce yourself.
Yes, Gord Francis from Novartis in clinical development. I had a question for Dr. Berger, sort of two-part question. And if you're withdrawing natalizumab and the drug levels are dropping, how do you distinguish between sort of the, if you will, because you can get these unmasking, if you will, an unmasked PML versus an MS flare, and the second part of that is an MS flare following a drug such as natalizumab, in fact, also defined as iris based on an antigen-driven immune response?
That can be a very difficult question, and actually you're jumping the gun because that's my talk in the next session, which gets to the diagnosis of PML and how difficult it may be in distinguishing from these giant MS plaques. I think Dr. Bozic showed a picture of somebody this morning who had one of these giant MS plaques and said, well, this is a giant MS plaque because we treated the patient with steroids and they got better and the spinal fluid was negative. I'm not 100% certain that that's always the case. I think that we're going to have to develop some diagnostic criteria, and I'm going to show you a difficult case very much like that. So unfortunately, I don't have all the answers. I don't even know if I have any.
Yes, please.
May I just add in addition to what Professor Berger said, Gordon. Of course, you know in the course of PML and natalizumab, you know where you see the new lesion. These patients are routinely MRI scanned, and you know that this new lesion is usually PML and virus associated. And in this scenario, you typically see the iris and the contrast enhancement associated with the primary PML lesion. So at least for me, of course, I cannot exclude that there is reactivation of autoimmunity and MS gets back exactly to that site and causes inflammation again. But it's located where you have the prominent viral load before.
Any further questions? Then I'd like to give the floor to Jean Major for some closing remarks.
I think we certainly have to thank all the speakers for keeping on time, and so we're getting close to actually recovering the time where we perhaps lost a little bit from this morning. So we heard some very interesting ways in which the brain responds to this kind of infection and how we try to approach ways to be able to go ahead and clear the infection in the brain. Igor was telling us about a few animal models that can be developed, perhaps using humanoid mice, but that didn't quite work out. And there's these barriers at a species level, almost what we see in prion science, and that there are these barriers that we can't quite get over. We have to understand the pathogenesis a little bit better. Some of the primate models, I think, which is an adequate model that I think needs a little bit of further work, and can we somehow retool this virus to go ahead and get it to work in a non-human primate model. Igor also told us that a number of small molecule drugs had been used in various culture systems that in the incubator it looks reasonably decent, but of course in a clinical study it didn't achieve that, any kind of efficacy actually, and that raises, I think, one of the key issues when you're looking at treatment for this particular disease, regardless of the underlying disease for an individual, or regardless of the treatment therapies that may induce PML in this, how do you deliver drugs to the brain? That is really a critical feature. And there are many conversations that many of us have had over the years that once a patient is diagnosed with PML and you have a good fulminant infection taking place in the brain, is it almost too late outside of having the immune system recognize that and try to clear that? So Teresa was telling us that perhaps you might want to go ahead and look at the virus life cycle and ask, well, where along the lines of how this virus grows may you want to interfere with this? And are there different novel ways to be able to look at this? Can you actually target antibodies for this? Certainly, this is an approach that's now being used and discussed extensively on campus at NIH in the treatment or to get rid of HIV infection in HIV-infected AIDS patients. Can you find that particular antibody that has the specificity? Perhaps the non-structural protein that Teresa had talked to us about, the T protein, multifunctional, does a variety of things, has enzymatic activity. Maybe that's a better target than looking at, for example, trying to block DNA replication, which gets it into the category of having toxicity towards the host cell itself. I think we'll always remember Teresa's talk because we need to have big, heavy-duty tools to put in our toolbox. I'm going to head over to Home Depot and that as soon as I get back to Bethesda to go ahead and fill that up. And also we need to take a look at the structural pillars of how you approach this, both in the basic biology of the virus and many other aspects that we have to understand more for. Of course, we had, and we continue to have quite a few discussions now about IRIS and this phenomenon that, as both Dr. Berger and Dr. Gold had told us about, we do really have a clear definition of what this is. After we recognize it, it is clear based on MRI scans that, in fact, you do have inflammation that occurs in the brain of all of these individuals. You not only see it in natalizumab-treated MS patients, but as Dr. Clifford had mentioned as well, you see it, extensively in HIV-infected individuals with PML, and Dr. Berger was telling us about the unmasking of PML in individuals, in HIV-infected individuals who actually, upon heart therapy, where their immune system begins to rebound, that in fact in a surprising number of individuals, it seems as if PML occurs as a direct result of immune reconstitution. And that can occur relatively quickly within a month or two or as much as 6 months to a year. That tells some investigators that perhaps what's happening is that there are cells within the periphery that are poised to enter into the brain or back into the brain and perhaps initiate infection. And what does that mean? Even in the presence of that, however, both Dr. Gold and Dr. Berger had said, even in the presence of IRIS, where you have substantial inflammation, where you have specific target CD4, CD8 cells, that in fact many of these individuals can never clear that infection. There's more we need to know about what that persistent infection, where it is, exactly how that's maintained within the brain. Certainly Plex versus immunoabsorption, or both, a case could be made for either. I think that probably, as we see more of these cases and that this is better defined and as we have more samples to be able to look at, then I think we'll get a much better idea exactly what the pathobiology is of IRIS. And I think perhaps some type of a study, an animal model, again, as we all would love to have, I think would make a big difference. So thanks again to all of the speakers. I think it was a remarkably good session, and I think we're back on time, and if I'm not mistaken, we have an opportunity to continue this discussion over coffee.